Hi, my name is Jamie Edmonds. You may know me from my 20 years in TV news, more than a decade at WDIV in Detroit. I'm Jamie Edmonds. Or you may have heard my voice for the past 3 years on the historic WJR 760 on the morning show. It was so fun to wake up Sunday morning, get ready, watch this game. I have told other people's stories for years. It's time to tell my own. I was diagnosed with breast cancer in February 2026. I am in the thick of the fight. Since that terrible phone call, angels have propped me up and supported me, starting with the two in my household, my husband Ryan and my daughter Olivia. Then the circle expanded to so many people, so many angels helping me get through this. That's why I named this podcast Angels Along the Way. I will talk to folks who treat this awful disease, those who console, those who assist, and those who inspire. I hope this helps anyone and everyone on a similar path. Welcome to this edition of Angels Along the Way podcast. I'd call it a special edition because I'm joined by Dr. Tiffany Troso. She got her degree from Princeton, went to Cornell for a medical degree, her residency at Cornell, and then an oncology fellowship at Memorial Sloan Kettering Cancer Center. And there she had 25 years treating breast cancer and gynecological cancers. And we have this very impressive person talking with us today, and I'm so grateful. Hello, doctor.
Hi, how are you? Thank you for having me. I'm so excited to speak with you.
Now, you reached out to me, which is, there's a dark side of the internet and social media, but this is a positive side, I think, because you saw my story, however I got to you, and you sent me a copy of your book, Calming Cancer Chaos, which isn't out just yet, but I got to read it. It's this guide for women to understand, organize, and take control of their cancer care. So I'm just so glad that you reached out.
Oh, my pleasure. It's interesting. I'm on Instagram. I've been growing my social media, and I guess it suggests to you different people that might fall into your genre or what have you. And it's interesting. A lot of doctors there are a lot of influencers out there that will say, "Oh, here's this TV personality, and she has breast cancer, and we're so sorry for her," and blah blah blah, and sort of make like a post out of it. And I kind of don't really like that so much. So what I do is if somebody comes across my feed and, the first thing I think to myself is, God, how can I help her? I want to help her. I don't want to make a big thing about this, but I want to help her. And so when I reached out to you, it was really just because I wanted to help. And I have this book and it's on my hard drive and it's coming out very soon. I'm hoping by August. And I wanted to get it to you because I really feel in my heart that it can help so many women with cancer. And so I wanted to get it to you as soon as possible so that it could make your journey a little bit easier.
And that it did. It really did. I read it in a day because
Wow.
it was a time when I was just trying to consume as much information as I could to understand what was happening to me. And I was just so scared. So it came at the perfect time.
Oh, good.
Before we get to your book, I'm
Mm.
wondering if we could just talk about your journey to becoming an oncologist and what brought you to this profession and what you've seen and sort of how things have changed. Because in the book, you talk about it's a better time to get cancer than it was even 20 years ago.
Oh, yeah. I mean, our advances at this point in time are exponential, and it's amazing now, especially with AI. You're going to see such a rapid development of new medications and drugs to treat cancer, as well as to diagnose and potentially, hopefully, prevent as well. So where do I even start? When I was a little girl, I was like 6 or 7. My grandmother, my mom's mom, had thyroid cancer. And I remember being in her apartment. We'd gone over there for dinner and she was showing me, and I was touching her neck, and she had this big nodule on her neck. And even at that age, I knew that wasn't right. So, fast forward, she had a very aggressive type of thyroid cancer, which apparently came from radiation therapy she had as a teenager, because there was experimental treatments. They were radiating people's necks from when they had sore throats. Imagine.
Oh my.
At any rate, so fast forward, my mom was her caretaker, and basically would take her to her radiation or chemotherapy appointments, and would always come back out. She would leave me in her white Pontiac with the red pleather seats, and she would come back out in the heat, because as we did in the 70s. And she would come out and always be upset and frustrated because the doctor wouldn't answer her, or she couldn't find the doctor, or she couldn't understand what was going on, what have you. And, even at that age, I didn't even know what an oncologist was, but I just knew that I never wanted to be a person that would make my mother so frustrated and cry, because I thought my mom was the strongest woman on earth. So fast forward, I go to college, I went to Princeton, and I fell into molecular biology, which at the time, back in 1987 through 1991, was
I
like
was just gonna
cutting
stop
edge.
I'll stop you there. You and I are different we differ there. I would never fall into molecular biology, but go on.
I've always loved science, and it was cutting edge at this point. And they were just learning all about DNA and oncogenes and all these things. And so I just thought it was fascinating, and I really loved the study of this science. And it was sort of the birthplace to a lot of the DNA work that we're doing today in cancer care. I took a year off. I did some research. I decided to go to medical school, went to Cornell, and started, did rotations, loved oncology. I found we got to rotate right across the street at Sloan Kettering. And so I really, began my affinity early for women, teaching, helping other women. I think because in some ways I'm a very social type of an animal, and I like talking to women. I like caring about and having friends and helping people. And so it was very easy for me to relate to other women. I ended up going through internal medicine, and it just wasn't fulfilling enough for me. And I went into oncology basically because I loved the science behind it. I loved caring for women, and I loved being in a place where I felt like I could really make a difference. And so that's how I got where I was for the last 25 years. I can jump
Did you
off.
just
Yeah.
recently leave Sloan Kettering? Is that a recent move for you?
Yeah. And so, I'm not very private about it. When I look at it like it's not my fault. I have a neurodegenerative eye disease. I'm losing my vision, and it's a rare condition, and it's very slow. I've been dealing with it for about 15 years, but I got to the point where it became increasingly more difficult for me to give the quality in my notes and writing my chemo orders. And I was always double checking everything, and it started taking me too long to do things that should take seconds. And I actually went out on disability, and
Mm.
I had that time to really, take a look at my life. And I was 55 at the time, and I was like, well, if I'm going to make a change, now's the time. I still have the energy and my wits about me, so I think I'll try it now. I had always had an entrepreneurial type of a bug in me, and so I really used my experience over these past 25 years to find, or well, I knew what it was, but to help work in an area that I thought was really lacking in cancer care. Basically, what I find is that women that have cancer and they go to see their oncologist, the oncologist needs them to understand a certain, amount of things, and wants them to participate in their care if they can. And then the patient needs another set of things. And there's a huge divide between what the patient needs and what the doctor's providing. And so I feel that that's an enormous gap in care. And so I have the knowledge, I have the experience, and so I'm trying to fill that gap for patients.
I love it because I didn't have a background in cancer. I had no one in my
Mhm.
family who had cancer. This was a shock to us. And then, like, within 4 days, I'm sitting in the oncologist's office talking about my care.
Yeah.
And your book starts with an appointment that changed how you practice oncology. And you say the woman was barely holding it together. That was me. I had the advantage of my husband being in the room and asking
Mhm.
questions.
Mhm.
But your book, the point of the book is to get you prepared for that first meeting. Is that right?
I mean, it's part of it. I think that, there's subsections that are applicable all along the journey. I mean, as you know, it goes all the way through the surgical components of it, and how to read your pathology report, how to differentiate the different types of treatments, all the way through survivorship and sort of how to reintegrate yourself into life. I talk about supplements, which is a little bit of a, um, quasi strange thing for a medical oncologist to be talking about, because it's considered to be a little bit outside of what we regularly do. It's more of integrative. But the reason I ended up including a chapter on that is because it was probably some of the most common questions that I would get in the office. What can I eat? What can I take?
Right.
What should I avoid? Like, those are three of the most common. Patients come in and we want to tell them, okay, these are the anti-nausea medicines you need to take, blah, 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 blah. But patients want practical information, like how to live on a day-to-day basis. What can I take? What can I
Right.
take that'll help me be better?
Right. And it's like plain language reading for someone who is a layman, to this world. And so I was
Mhm.
able to understand. I went back. I got the book after sort of, I don't even know where I was, but I had already started treatment. So I went back to read it all, and it explains what's happening to you. And,
Mhm,
they tell me I have triple negative breast cancer. Why is that
mhm,
different than the hormone receptive cancers?
mhm,
And I think that's really great. I mean, it's just something that I wish I knew when I walked in.
mhm. Yeah.
Yeah.
But still, you're going to be making future decisions for the rest of your life, and so the more you understand about where you've been, the better decisions you can make about where you're going in the future. So I think education is power. So
Part of the book is learn how to choose your team and how you
Mhm.
advocate for additional services. Can you talk about that?
Well, yes, absolutely. So there's a couple different layers. Do you want to talk about on the medical side or on your personal side?
Let's talk medical side because you're
Okay.
just so darn smart.
Thank you. So basically, to choose your medical team, you need to, fulfill a couple of things. One, you need to feel comfortable with the doctor. You need to make sure that they are going to spend enough time explaining things to you, that they give you options so that you can weigh out your different choices, and that they will answer your questions when you ask them. There are plenty of brilliant doctors out there, but not everybody's a good match, right? And sometimes it's hard to know even on the first appointment. There are days that even doctors have bad days, right? And I'm running really far behind, and my poor new visit has been waiting for an hour and a half, and she's anxious to begin with, but you never know what's in the next room, which could be somebody who's at the end of life or having a family crisis or whatever. And so it's I used to say that whatever each room that I walked into was like walking into a whole new world, because you never knew what was actually behind the door half the time, and you had to meet them where they were. At any rate, so that's the medical oncologist. You need to find a surgical oncologist, somebody that's potentially going to do your surgery. Um, you might need a radiation oncologist if you're going to do radiation therapy. Oftentimes in the oncology world, patients enter the system through the surgeon first. And then the surgeon will make the referral to the medical oncologist. And so it's not a bad idea to ask the surgeon, like, what you know about me and my personality, who do you recommend that I see? Because it doesn't necessarily have to be the next guy on the list. Maybe it's the lady that's two down on from the top of her list. At any rate, and it's not a bad thing to get a second opinion if it doesn't feel right or you're not getting the answers that you feel like you need. Then get a second opinion. It's always, it's all. I used to tell patients that it's not about me as the doctor; it's about you as the patient, and you need to make sure that you're understanding everything and you're making the best decisions for yourself. And maybe the next doctor will explain something better than I did, or you'll understand something better, or perhaps that hospital has a different option that I don't have available for you. Um, some of the other people that can cross your life while you're in treatment will include things like a physical therapist or an occupational therapist. You might end up with some lymphedema in your arm, for example. You might have numbness and tingling in your fingers. You might want to see integrative medicine and or see an acupuncturist, for example. I use a lot of acupuncture for patients with nausea, with severe fatigue, and peripheral neuropathy, and which is numbness and tingling in your fingers and toes. Let's see what else. There's
That's
social
interesting.
workers.
That's
Yeah.
interesting as a medical, person with a medical background that you do
Mhm.
support this holistic approach, that you believe in acupuncture.
Absolutely. I'm actually participated in several clinical trials. I think I'm published in one or two of them. I think that and my belief in this has actually grown substantially since I've left academic medicine. Now that I'm open to the whole world and I'm taking things in and I'm not necessarily just drinking the Kool-Aid, I I've learned a lot about functional and integrative medicine. And in my perfect world, in the next couple of years, the two are going to integrate, because I don't think either one is completely right. And I think there's going to be some sort of an intersection that hopefully will help patients meet them at many different levels.
Interesting. I feel so lucky. I'm at Henry Ford, if you know about it, in Detroit, and they
Mhm,
have all of that in one building. They have a cancer center, they have acupuncture, they have the workout Excite program, and I
mhm,
feel enveloped by a lot of people helping me get through this. So,
right.
um,
Well,
I
that's
haven't
great.
I haven't tried the acupuncture yet. I was telling you actually that my side effects I've been managing them, but maybe I look into it.
Maybe. I mean,
Maybe.
if you have time in your schedule for yet another appointment, but
Right.
anxiety and insomnia, it helps as well.
Ooh, it has been hard
So
to sleep. It has I'm very hot at
hmm,
night.
hmm. Well, I don't want to ask you any personal questions, but it might have something to do with your hormone levels.
I think it might actually. Part of this book that you've written also has an accompanying workbook, which I
Yes.
think is cool that you can sort of take notes, follow along, and you advocate for people who are starting this journey, get a binder. Why?
Mhm. So I love to tell this story about a patient. She's actually about 10 years ago. And she was not from this country and she didn't speak much English. They were originally from India. And the patient came with her husband and her daughter who spoke fluent English. And this poor lady, she had gotten another opinion somewhere and wasn't doing well and wanted a second opinion. So the patient walks in, she sits on the table, and she was sort of relying on her husband and the daughter to give me all the information that I needed. We also had an interpreter, but she liked hearing from her husband. So at any rate, um, every time I asked them for something like, oh, do you have your CAT scan from 6 months ago? I want to see that report to compare it to this new one that I have, because we didn't have a complete records in the chart. And I don't have a good bag to show you, but let pretend this is a shopping bag, right?
Right.
And the husband has this shopping bag and there's literally like papers like shoved in it and whatever. And every time I asked him for something, he would ruffle through the bag and like pull papers, and there's papers flying, and the daughter's screaming at him because he's such an unorganized mess and whatever. And you could feel the tension in the room. And the patient was like upset now because you can't find the CAT scan report. At any rate, long story short, we got through the consultation. I finally asked him for the
That was
bag.
probably was one of your longer ones, and people might have you've gotten
Oh, they were
behind.
waiting. They were waiting. That's right,
Yeah.
sure. So, because I always tried to give patients the time that they needed. But at any rate, I sent the husband and the daughter to Staples. I put the patient in the back room because she needed hydration and she got
We are not
chemo.
sponsored by Staples, by the way.
We're not an office
That's
supply
good.
store.
That was a joke. That was a
An
joke. Go
office
on.
supply store. Anyway, and had him get some of the things for the binder, 2-inch binder, get me a hole puncher, get me, the sheets that you can put it in and dividers, what have you. And I took his bag, and during our quote unquote lunch period, my nurse and I went into the back room and just sorted all of his papers, put them in medical chronological order in the sections as I describe in the book, hole punched them, put them into the binder, labeled the binder, and handed it to him while he was sitting with his wife in the back room. I mean, this man, he burst into tears. And something that was not difficult for me because of what I do every day made such an enormous difference for this man and his wife and family, because I handed them back some control,
Mhm.
and I gave them a sense of organization, a little bit of control where it's hard to find any control in cancer care. And I just realized that like some of the things that I take for granted really could help cancer patients so much. And so yeah, I have a whole chapter on the binder and the my planner that I recommend that you use. So, and people can do it now electronically, and I'm sure some of the 20 somethings that might hear this will be like, why would I carry a binder? Like, why would I carry a planner? But I'm old school, I'm paper.
Yeah.
And yeah, I just think that it's really important to help patients have a better sense of what's going on if they have it all organized.
Right. I think that would be very beneficial. And I'm a millennial, so I could get a trapper keeper and put everything together. Another question for you. Chapter 12. I'm sort of like moving toward where I am now. Now it's
Okay.
managing side effects is chapter 12. And then you move forward in your book and it's how many more appointments, doctor, maintenance therapy. That's something I haven't thought of. I thought, okay, I'm done with chemotherapy. I get my surgery. I go about my life. And my surgeon a couple episodes ago has told me that she needs to see what's in there, which will dictate what we do after that. But
Correct.
maintenance therapy, what is that?
Mm. So it's not a bad thing. It's a good thing. So patients, depending on the type of cancer that they have, there's all the different types. There's a hormone receptor positive, there's a HER2 positive, there's a triple negative breast cancers, and they all have different genres of what we call maintenance therapy. And for triple negative breast cancer, it usually will mean either additional oral chemotherapy. It could mean probably, if you're on immunotherapy, continuation of that immunotherapy for another year. It could mean a PARP inhibitor, for example, if the patient had a BRCA mutation. And the whole idea is to sort of consolidate what we have, right? So if you had a complete response to your treatment and you go to surgery and they don't find any active cancer anymore, maintenance therapy would not include further chemo, most likely. It would probably include the immunotherapy and or the PARP inhibitor versus a patient that might have residual cancer that's still present at surgery. Well, that means that we didn't get it all and that there are still some cells that are circulating around and that we're going to put you on, there's been trials, one's called the Create X trial, where we give an oral chemotherapy called Xeloda for a period of time. And that has shown to decrease the likelihood that the cancer comes back. And so,
which is what we all want.
Which is what we all want. You can also think of it kind of like a consolidation therapy, just cleaning up.
Okay. All right. Good to know. I'll try and think of it like that. Like it's a good thing if I have to do it. You're on Instagram. That's how we initially connected. You're at Dr. Tiffany Troso, and you're posting lots of videos of things that are going through my mind. So I'm obviously relating to you. So I wanted to bring up a couple of your posts. You finished treatment, rang the bell, everyone celebrated. No one warned you about the fear. And then you give some tips. That's not something I thought about either.
Yeah. You know, the problem is that when patients are on active treatment for their cancer, you're seeing us, you're seeing the doctor, you're seeing your medical team on a regular basis for treatment. All of a sudden you're done, and you feel abandoned, right? Because you're not seeing us as frequently. We're not checking in on you all the time. And we tell you to come back in 3 months or something. It's like, what am I supposed to do between then? Am I going to be okay for 3 months? And, you know, that's something that we don't, you know, normally a lot of doctors wouldn't think to even tell you. But we know it's the case. There's a significant like abandonment feeling and a feeling of you know, being lost and sort of just thrust back out into life and not really even knowing how to reintegrate. And so that's what I was addressing there.
What's one of the tips? Do you mind giving it out?
Well, I think first and foremost is acknowledgement that this is going to happen and that you're truly not, you know, abandoned and that we are still here. God forbid there's a problem. You call me, you send me a message in the portal. And I think it's important to also acknowledge the fact that you're not going to feel normal the day that you're done. It's going to take time. I think some of the milestones are 6 weeks, or maybe 3 to 4 months, 6 months. 6 weeks is when I say your hair might start to grow back if you've lost your hair very slowly. Usually it'll be a good 9 months before you have hair that you'd be happy wearing without a hairpiece, if you're so inclined. And, you know, patients will come and say, I think I cover some of this, like, when can I get my teeth cleaned? When should I get my eyes checked? Going back to all those normal things that you normally would do that had been put off while you're on chemo. I use the 6-week mark for that because it's usually when most of the chemo and the side effects are out of your body. And, you know, you can get your teeth cleaned safely and you can, you know, go get your eyes checked. It's important not to change your prescription, for example, while you're on treatment, because you can have fluid shifts in your eyes. For example, if you're getting steroids, you get a little swelling in your eye and your prescription will change. But the last thing you need to do is go out and spend, you know, $900 on a new pair of glasses that are not going to be right in 6 weeks or so. So those are some, you know, just sort of give yourself grace and realize that, you know, every day step forward and you're not expected to, you know, reacclimate to all of the world immediately.
Right.
You have to, you know, prioritize what's important to you and, you know, work after those goals.
That was very thought-provoking. I thought that post. The other one I wrote down from your Instagram was you had someone maybe in your office or recently when you were at Sloan Kettering blaming themselves for their diagnosis. I mean, it's hard not to when it's like, I don't have family history. So is it something I've done?
Well, is it something you've done? It's not just something. No, nobody does something to themselves to give themselves breast cancer, for example. I mean, obviously, there are some cancers that do have direct correlation. So patients that, you know, have lung cancer always will ask if they were smokers, did I do this to myself, for example? But there are plenty of patients that get lung cancer that never smoked. And so, you know, you have to look at, if, in my opinion, scientifically, it makes sense that everything that happens to us and around us is a mixture or a combination of environment and genetics. And the two are interplaying with each other constantly. And so was there an exposure that we had, you know, 25 years ago when I used to eat lean cuisines in those plastic containers that I would microwave and eat them like literally every day for lunch.
Which I did
Right.
do as a new
So
journalist,
who
100%.
didn't? Well, we're probably around the same age. I mean, who didn't, right? And how about the water bottles that we were drinking out of, and the cell phone that we keep in our front pocket, or there's a million things. There's a million things out there, and we only know what we know, and we can't necessarily prevent things we know that we've done in the past. I used to sunbathe with baby oil, right? I used to go to tanning booths. Like you go in and you lay down like it's a freaking coffin, and it closes down on you, and you sit there in plastic and sweat
Yes.
so that I would tan.
And you would put little stickers on your skin, so when you came out of the tanning booth, you could see the little outline of the sticker.
All right, I didn't do that, but
Oh, excuse me.
no, just kidding. No, but I'm just saying that, how do you blame yourself for that? I mean, my mother probably didn't think it was a good idea, but she didn't have no reason. She didn't have any reason to tell me not to do it at that point. Right?
Do you subscribe to this, like, we need to be cleaner and have cleaner products, our toothpaste and what we wash our clothes in and all that? Do you subscribe to that?
Oh, yeah. That's a tough one. It really is. And I think it's a matter of what I call dose, right? And so I think I go through in the book about some of the things that I think are the obvious, easy ones. You could go crazy. You could spend the rest of your life trying to replace everything with something organic. But, my daughter went to Whole Foods now because she's on a health food kick. And so she went to Whole Foods and bought paper towels there because they're not bleached and they're this and they're that and they're healthier and blah, blah. They stink.
They're probably also $1 million.
Right. They're $1 million. She bought a 3-pack. I'm like, clearly you've never run a household, honey. You never buy 3. I buy like 12 at a time, right? And they stink and they don't hold up to clean anything. You go to dry your hands and your hands go through it. Anyway, I jest, but you could go crazy. I think you need to look at the things that are most significantly giving you the toxins. And so, the easy things to remove is anything plastic in the kitchen, right? Where I threw out, 15 black plastic Teflon, whatever, spatulas, and I replaced all of my Teflon pans, and I'm using stainless steel, which I don't really like, but I think it's a little bit better. And until they find something that they think is also safe and better than that, that's what I'm using. It's so hard. I threw out all my plastic Tupperware. I use glass containers now, right?
Yeah.
I mean, I made the simple swaps. They do say that some of the skincare products that we use, that you really should be looking for ones that are, PABA free and don't have any this, that, and the other thing. And I go through that in my book and such, because skincare and personal care products are something that we use on a regular basis every single day.
Mm-hmm. And it's certainly going into the bloodstream if it's right here on our skin, right?
Yep.
Yeah.
But I do have to note that there has never been a clinical study that showed that regular antiperspirant deodorant actually leads to cancer.
That's something you hear all the time.
All the time.
There's never been a study. The ones without aluminum do not work.
They also stink.
Yeah, they do.
No, I know.
No pun intended, right?
Right.
I also run a comedy show. Anyway,
I love it.
Couple questions. I elicited some questions from people on Instagram who are now following me because I talk about cancer. And if you don't mind, I'd like to ask their questions.
Sure.
Okay. So Jane sent me a question, and she said, folks with benign conditions that elevate risk, such as ADH and ALH, and for those that currently have currently have breast cancer, can reduction mammoplasty play a role in overall risk reduction? She says a plastic surgeon says yes, an oncologist says no.
Okay. Let me first define for your audience, in case they don't know what ALH and ADH are. So there's 2 different types of cancers. There's lobular cancer, which comes from the lobules, which are like the milk, where milk is made in the breast. And then there's the ducts, which carries the milk out to the nipple. So there's ductal cancer and there's lobular cancer. And so ALH is atypical lobular hyperplasia, and ADH is atypical ductal hyperplasia. So they come from different cells within the breast. Cancer forms along a continuum. So I often explain to my patients that it will come, a normal cell, something will go wrong and it'll start to overproduce itself. And they call that hyperplastic, right? And then the cells start to overproduce themselves and they start to become a little irregular looking. And that's atypical hyperplasia. And then along that continuum is in situ cancers. So cancers that they're pre-malignant, but they haven't gained the ability to move and spread anywhere else. So those are in situ, ductal carcinoma in situ, DCIS, or lobular carcinoma in situ, LCIS. Again, moving along that continuum then turns into an invasive cancer. And invasive cancers along that continuum is grade 1, which looks the most like normal cells or an atypical, hyperplasia, all the way to grade 3, which is a grossly abnormal appearing cell under the microscope. And, there's more sophisticated ways, obviously, to explain that and to define it molecularly, but cancer forms along a continuum. So if a patient has had ALH or ADH, these are atypical hyperplastic cells, it is a risk factor for future development of a breast cancer. ALH in particular has been shown to, just like LCIS, can cause breast cancer in either breast and doesn't necessarily have to be in the same area where the LCIS was originally found. So when surgeons go in to remove lobular carcinoma in situ, which is the next step after ALH, they don't even worry about clean margins because it's considered what we call a field effect. Whatever caused the ALH here probably affected all of the tissue. And so partial mastectomies or mastoplexies, partial, if you're not removing all the breast tissue, it's not going to be an effective way to reduce your risk. ADH is a little bit different. It's usually, more of a localized problem. But again, ADH is also showing you that there's a risk in that breast that the tissue's been exposed to something that's making it abnormal. And so, I don't think a partial mastectomy or a, mastoplexic partial is going to necessarily negate that risk. You have to remove all of the tissue. But before anybody jumps to book their mastectomies, I think in both circumstances, that is way far unnecessary in terms of medical prevention. There's a pretty, long road between ALH, ADH, and invasive cancer that, especially in this day and age with our radiology, that should be able to be picked up if you're getting your screening regularly. And if a patient has had ADH, they're going to get a higher level screening than somebody that has had no history of cancer at all. So that's my talk about that. And there you go.
Jane, there you go for that one. This is my question here. What are your thoughts on if you are a candidate for lumpectomy or do the mastectomy? Like if you can choose between two, is there one that you choose always or it's up to the patient?
Well, it's up to the patient. The studies have shown that, given if a patient is actually eligible for a lumpectomy, in other words, the tumor is small enough, it's in an area that can be completely removed without significant cosmetic defect. So some people that, have an A cup sized breast and have a 2 centimeter sized tumor, and the surgeon has to cut around it to get clean margins, then they might not get a good cosmetic result from a lumpectomy. But the studies have shown that lumpectomy in the appropriate patients with radiation therapy afterwards are equivalent to a mastectomy in terms of cure or decreased risk of local recurrence and distant recurrence. So I think it's really, once a patient understands their risks and the risk-benefit ratio of either procedure, I think that they're equivalent.
Okay. Cece asked, would love to know if there are any ideas as to why so many young women are being diagnosed. Is that true, or is she just noticing it more because she's been diagnosed?
No, there's definitely statistics that there's a rise in early breast cancer. And it's really quite a problem. And it's really quite concerning because a lot of times young women will go to the doctor and really get brushed off because they're like, you're too young to have cancer. So I always make sure to state very clearly, even if you're 27 years old and you feel something that's abnormal, say something. And if you don't get the answer that you need, or you don't get a radiology test to take a look at it, go ask somebody else because it needs to be looked at. And we can't just poo-poo younger patients and say you're too young to get breast cancer anymore, because that's not the case. We're seeing it more and more. Do we know why? God, I wish I knew why. It could be a lot of things. It could be different hormone disruptors that are present in our systems that are more prevalent now than they used to be, for example. Oh, going back to that from before, the other thing I forgot to tell everybody to get rid of in their houses are most of your candles. Any of those candles that you burn, unless they're soy and they specifically say that they don't have benzenes and this, that, and the other thing, they're bad. They literally leak toxins into your air. And trust me, I can't tell you how many candles I used to own. I had one for every day of the year.
Right.
And every
Pumpkin
holiday.
spice, forest green for Christmas. Yeah, get rid of all those candles.
You gotta get
Okay.
rid of them. You gotta get
All
rid of
right.
them. There are companies that make diffusers and candles that are safer, but you have to specifically look for those. I'm not going to name any companies, but
Right. Okay.
your general candle from the common candle stores that most people go to are not probably very good for you anymore.
Interesting. Interesting. Okay. I
But I
did not know that.
But I digress. Where
All right,
where was
couple
I
more.
with that? Okay.
Sasha, a diet question, which you talk about this in your book a little bit. Any pointers on healthy eating? I think artificial crap is not helping us. Healthy food is expensive, however.
Mm. Well, the question is, how do you define healthy food? I think that one thing to consider is when you're deciding on what you're going to put in your body, is it a whole food? Can you actually describe where it came from? And can you pronounce everything that's in the ingredients, right? And so, an egg is definitely is a whole food. An apple is a whole food. A piece of chicken breast, I buy organic. Is that going to make all the difference in the world? I don't know, but that's what I'm doing right now. And I think that it takes more preparation to eat healthy than anything else.
Yeah.
That it doesn't necessarily have to be expensive. Black beans you can boil and put over brown rice, or what's my other favorite, like quinoa and farro. Have you ever tried farro? I love farro.
I believe so. Yeah.
Farro, it's like, it has a little more, like, it's kind of like brown rice, but it has a little more chew to it and a little more substance. It has more protein in it than other grains. It doesn't have to be expensive. Looking for fresh fruits and vegetables. You're looking for, chickens and fish that are fresh caught, not farmed. It's not going to be cheap, but to be honest with you, buying McDonald's isn't cheap either. So I think it's just a matter of preparation. And, unfortunately, this is the world that we're living in right now. Unless you want to buy Trader Joe's or Whole Foods, prepared meals, which are very expensive, you're going to have to prep your own stuff.
Yeah. Okay. D says, I had the fast forward radiation treatment 5 days instead of 5 weeks. I'd love to hear the doctor's take. She didn't have any side effects.
Perfect. Well, that's great. So the thing to mention is that not everybody is eligible for that radiation therapy, right? And so these are usually earlier stage, smaller cancers with the right breast size and architecture. So it's not everyone that should be getting it. So if you weren't offered that, it's not necessarily that you were gypped. It was that you might not have been a good candidate for it, or your institution didn't have it. But yeah, I've seen that as well. It's, they were using it at Sloan, and in the right patients, it has been shown to be equivalent and definitely has less side effects.
Okay. Lindy asks, what do you do for your gut after chemo? Stomach wrecked after chemo.
So that's a tough one. I can give you the conventional answer, and then I can give you some of the functional medicine answers. I mean, essentially, chemotherapy, the steroids that you're taking, you might have gone on a course or two of antibiotics, you weren't eating the same, your gut flora is going to change. And so, yes, a lot of people have changes in their gut health, so to speak. And so I think it's really important to try to renormalize that. And unfortunately, it's not as easy as just taking a probiotic, because oftentimes you've got to kind of clear out or rebalance what's in there before you can supplement to replace. And what does that mean? There are sometimes you need to look at gut cleanses. You need to look at increasing the fiber in your food, making sure things that are called probiotics are actually a type of carbohydrates or fibers that actually feed the good bacteria in your gut. So you should start with a probiotic. If your gut is really problematic and you're really not getting better, besides seeing a gastroenterologist, other things you can do in the functional medicine space is do something called a GI map, where you send stool off to get it
Cool.
analyzed.
Fun.
And they will,
Neat.
It's not that big of a deal. Anyway, it's just poop. I think I had a book for one of my kids when they were little that everybody poops.
I've read that book
Um,
to my 3-year-old. Excellent work. Excellent work.
it's a good book.
Yeah.
So, they analyze your poop and they look at, do you have an overgrowth of, particular types of bacteria? Are there supplements you can take to help reduce those? Are there foods that you should be eating to help augment the good bacteria? Do you have a yeast infection? That's actually pretty common as well. So most GI doctors won't necessarily do that, but they will look at stool studies.
Mm.
And so, depending on the range of how disturbed your GI system is, you might need to see a gastroenterologist and just tell them, look, I got chemo and I never got better. What do I need to get back to where I was?
Yeah.
But there are plenty of things that could be done. And I'm not sure if I addressed some of those. I don't remember reviewing that so much. I talk about constipation and how to manage that. But, there are certainly, if anybody's listening, if you want to reach out to me on my website, for example, there's a place where you can ask a question, send me an email. I'd be happy to, fill you in on some more information that I have.
Excellent. Actually, you remember Dave Coulier from Full House?
Mm-hmm.
I just had him on the podcast and he was talking about how he didn't poop for a long time and he had to talk about it with his wife. That
What
cancer
did
is
she
not
say?
sexy, he said.
What did she say? Did she give him good advice?
Well, when it finally happened, they had like a big party, I think. Last question from Julie. Oncotype scoring, what do results mean at different scores?
Okay. Well, it also depends on where you are, premenopausal or postmenopausal. So in younger women, it means something different. The general population in postmenopausal patients, we're looking for an oncotype score above or below 25. And essentially what the test is looking at, the DNA, certain genes in the cancer itself, in the DNA of your cancer, to see what it's sensitive to and what it's not. And the test helps to determine whether or not in an ER positive, hormone receptor positive breast cancer, whether adding chemotherapy to anti-estrogen therapy is beneficial. And if so, how much additional benefit would you get from it? So a patient that has a very high oncotype score normally would get chemotherapy followed by hormone therapy. And so it's an important test because there are patients out there that can safely avoid chemotherapy if they have the right score.
Oh.
There's another test that's out called Mammoprint. And there's another one, I believe, called Prosigna that I don't use, but it's not, Oncotype isn't the only one out on the market. And then there's another test if you have hormone receptor positive breast cancer that you should know about called BCI, Breast Cancer Index. And that test we run around year 4. This is for hormone receptor positive breast cancer patients that have had hormone therapy, regardless of chemo. They've been on their anti-estrogen therapy for 3 to 4 years. We send this BCI test. Again, it does a DNA analysis that helps to evaluate whether or not the patient would benefit from being on prolonged hormone suppression. So should the patient take the hormone for 5 or 10 years? And so that's an important test to get done as well.
Just surprised. There's just one more. Teresa says, what specific genetic testing should I ask for if I have family history?
It's not for you to have to, hopefully not for you to have to tell them what to do. They better know what they're going to do, but they should send off a full cancer risk profile. My risk is what it's called. And there are a lot of genes now it's not just BRCA1 and 2. There's a whole slew of other genes that contribute to various different types of cancers and can rise to risk of breast cancer. BRCA1 and 2 are the most well-known, but there are others out there that put you at risk for breast cancer, as well as other cancer syndromes that should be tested for. So I would just ask for a full genetic DNA profile.
Okay. I have really enjoyed our conversation. We've touched on a lot of things. There is a portion on your website where it's like, get to know me. Seems like you're a really big tennis fan.
I played tennis for years. Years and years. Actually, let me back up. I learned how to play tennis and played tennis all through my childhood and high school. And I played 1 year JV at Princeton. But I
okay, D1 athlete.
No, I was like a hitting partner. Like they would just slam it at me. But no, but I did play D1 soccer. I played soccer for Princeton.
I did not know that.
Yeah, I tore my ACL my junior year. So that was the end of that career because in 1990, ACL repairs were not as prevalent as they are now. I had one done, but then they wrap you in this like huge brace and then you tape it. And I was a winger, so I was a sprinter. And yeah, you're not running anywhere very fast in that brace. So that was the end of that.
Meanwhile, these days, like the football players get it and they're like back the next season. Fine.
You should look at my son, Tyler Sandoval. He was a lacrosse D1 athlete he played lacrosse at Princeton and then at Villanova. He has a whole company he's building called Injury Conquest, where he's come back from, you can't even believe how many surgeries. He's like a robot at this point, but he was back 9 months after his ACL.
Wow.
It's really crazy.
So things have changed since 1990 in the ACL space and the cancer space.
Yes, just a tad.
All right. Well, your book is called Calming Cancer Chaos, an oncologist guide for women to understand, organize, and take control of cancer care. It's not quite out yet. How can people get it?
Sure. So if you go to my website, drtiffanytroso.com, there's a link where you can sign up to be on my pre-order list. I'm not doing, you can buy it on Amazon as a pre-order of a Kindle book, but I'm actually creating an email list that I will send out to people when it actually gets published, because I'm looking to, I would like patients to get the hardcover, and actually it's a soft cover, and I just think that it's better, but you can get the Kindle book on Amazon right now. But at any rate, you can go to my website and it is covered there, and you can sign up to get on my email list. Don't worry, you're not going to get spammed. I'm too busy to bother you too much, but I also, you know what else I want to mention is I have a Shopify store that I just started called the Empowered Patient Store. And it is a culmination of all the things like Amazon stuff, basically, that I used to recommend to my patients. So, a patient would come in and have, abdominal pain because she just had ovarian surgery and she needed an abdominal binder. You can buy, I have a link to that there. I have links to the coolers that my patients have used, the cooling gloves that they use, and all kinds of stuff that just makes it easier, like just stuff that I have vetted out over the years. It's an Amazon affiliate link, so I make 12 cents per each sale. So it's not like a moneymaker. It's really
that builds up.
No. But the point is that, I used to, when I was in clinic, I used to pull something up on Amazon and just tell the patient or her daughter to take a picture of it, a screenshot of it, and go home and order. It's really just a convenience factor so that people know what to order and stuff. So.
I think that's great, because someone, when I was doing the cold capping, suggested the hand things that I got on Amazon, the cold hands and feet thing when I was doing the Taxol. And that was great because I wouldn't have known about those. So great. There's one space where people can find all of your tips after 25 plus years treating breast and gynecological cancers.
Which is amazing because I'm only 40, right?
Yeah, how'd that happen? You're 28 years old. You were, what's that doctor who was like a child doctor TV show?
Hauser.
Doogie Howser.
Doogie Howser, yes.
You're like Doogie Howser.
Yeah, right.
Anyway, thank you so much, doctor. I appreciate you for reaching out to me personally, and now you've reached out to anyone who's listening to this podcast. I think that's great.
Oh, my pleasure. And I'm so honored to have been here. Thank you so much for having me as a guest. This was a great conversation. Thank you.